This is Dr. Lyle Jones, Editor-in-Chief of Continuum, the premier topic-based neurology clinical review and CME journal from the American Academy of Neurology. Thank you for joining us on Continuum Audio, which features conversations with Continuum's guest editors and authors who are the leading experts in their fields. Subscribers to the Continuum Journal can read the full article or listen to verbatim recordings of the article and have access to exclusive interviews not featured on the podcast. Please visit the link in the episode notes for more information on the article, subscribing to the journal, and how to get CME.
This is Dr. Teshamae Monteith, Associate Editor of Continuum Audio. Today I'm interviewing Drs. Meredith Barad and Marcela Romero-Reyes about their article on orofacial pain, which appears in the October 2024 Continuum issue on pain management in neurology. Welcome to the podcast, ladies. How are you?
Excellent.
Fine. Happy to be here.
I am so happy to see you. I mean, I think both of you I've known for like 10 years.
Yeah. Yes.
So why don't you introduce yourselves? Well, I know you, our audience, some of them may not know you.
Okay, I'm Dr. Marcela Romero-Reyes. I am an orofacial pain specialist, clinical professor, and director of the Stanford Facial Pain Clinic here in the University of Maryland School of Dentistry.
Excellent.
My name is Meredith Barad. I'm a clinical associate professor at Stanford, and I work. I'm the co-director of our headache and facial pain clinic in the Stanford Pain Management Clinic.
Well, first of all, thank you for writing this article. It is extremely detailed and up to date and very informative. And in neurology, I think we don't get enough pain management. I'm interested in both of your backgrounds and what led you even to become an expert in this area. And both of you have complementary areas I think we can see in the quality of this article. But why don't we start with you, Dr. Romero-Reyes?
Well, for me to get interested in orofacial pain, I will say more than an interest was like a calling that I wanted to take care of this patient population. So as you know, my background is dentistry. And at that time, I was very interested in patients with complex medical issues. And was the time I started to be interested in temporomandibular disorders. But what really piqued completely my attention was the first time I saw a patient with trigeminal neuralgia. This was my last year in dental school. This patient already had like almost the full upper quadrant of teeth extracted where pain was not resolved. So when the patient came to us and I did my exam and I triggered the pain, the sharp shooting electrical pain that really broke my heart. And I took an x-ray and I didn't find anything that would explain me was something wrong until I talked to my professor and he said, no, this is medical. There's nothing wrong with it, with that tooth. It needs to be, followed with proper management and medication. And for me, that was like, wow, what a proper diagnosis and proper management can take care of these patients. And when the patient got better, that really said, oh, I want to do this.
That's a crazy story. It's always that last patient of the day.
Yeah, and think about it. At least in dentistry at that time, I learned about trigeminal neuralgia from a book, right? My classes. But when you see the patient, this is it. That completely, make me say, yes, I want to study this.
Yeah. And unfortunately, that's not an uncommon scenario where patients with trigeminal neuralgia get, their extractions, and pain can sometimes be more complicated. What about you, Dr. Barad?
Well, I guess I'm sort of like the opposite. So as a neurologist and a trained pain physician, I saw a lot of patients with neuralgic pain and headache pain. But I also saw many patients who would say, I have TMJ. And as Dr. Romero has educated us, that's like saying I have shoulder or I have knee. But I quickly realized that I needed to work with a multidisciplinary team to really understand more about orofacial pain. It's not just neuralgic. There are other etiologies, and so that's how we started working together, and that's how we practice in our clinic at Stanford.
Cool. So why don't you tell us about the objectives of this article?
I think our objectives were to help the neurologist broaden the differential diagnosis on facial pain to encompass below the nose, the oral cavity, the temporal mandibular joint, and to just think more broadly about facial pain and to understand some of the more recent diagnostic criteria that have been developed for facial pain and to how to diagnose properly and how to begin treatment for some of the other conditions that are non-neurologic.
And I think I will add about what Dr. Barad said, that also to bring awareness to the neurologists about the vast classification of orofacial pain disorder, craniofacial and orofacial. I think that was also a key thing too. And also to show how well we can work together, the multidisciplinary management that is indicated for these cases.
Cool. And you mentioned some of the new diagnostic criteria. I want to talk just briefly about the new International Classification of Oral Facial Pain, ICOP. When did that come out, and what was the process there in really fine-tuning the diagnosis of oral facial pain disorders?
So in 2019, the Orofacial and Head Pain Specialist Interest Group of the International Association for the Study of Pain, the International Network for Orofacial Pain and Related Disorders Methodology, and the American Academy of Orofacial Pain, and the International Headache Society, they partnered together to develop this international classification of orofacial pain. And this, I think, is such a great effort. All the main people doing pain about this area, and goes very well together with the International Classification of Headache Disorders. So, for example, some disorders that the International Classification of Headache Disorders doesn't present, such as, and the ICOP, the International Classification of Orofacial Pain, presents, like the persistent idiopathic dentoalveolar pain. You have it in the ICOP. It's not, mentioned in the International Classification of Headache Disorders, as well as also we have I think it's item number 5, the orofacial representations headache disorders, so primary headache disorders. The ICOP gives you a nice, clean diagnostic criteria.
So I guess I would ask Dr. Barad, with this classification in mind, how useful is it in neurology practice? And I know obviously you see patients with pain, but how useful even in managing patients with headache?
I think it's great because I've had a lot of dentists and ENT doctors who have started referring patients to me because they've realized that they've increased their awareness about orofacial pain and realized that pain in the sinuses, for example, accompanied by light sensitivity and sound sensitivity and rhinorrhea, may not be a recurrent monthly sinus infection.
Yep.
And so that kind of broadens our awareness of these disorders, and it's brought new patients into my clinic that we can help and treat. So that's been exciting.
And what about in the world of dentistry? Obviously, I think people in oral facial pain worlds are highly attuned to this, but I would hope this would hopefully have been disseminated into dentists in regular practice that see patients with trigeminal neuralgia.
Going back for the what you were discussing about the ICOP, so it's what we're trying now as a new specialty. Well, that we have been for the last 40 years, but finally in 2020 we have been recognized by the American Dental Association to disseminate this knowledge. But also, can you imagine in the realm in orofacial pain or dentistry, to have a patient with this recurrent pain, phonophobia, photophobia, throbbing, dental pain is throbbing, but it's nothing wrong with your tooth. And that they tell you that actually you have an orofacial or facial migraine or a neurovascular orofacial pain. How crazy, right? And that is managed with migraine therapy. So it really, to make you think like that, wow, so this weird toothache that used to come every week, or this weird facial pain, it's nothing to deal with, with my teeth or any structure, inside my mouth.
It sounds to me like what you're saying is that this has encouraged patient education as well.
Oh,
So
yeah.
not only interdisciplinary education, but really helping provide an explanation for the patient about what is going on with them. So rather than just getting sent away to another tertiary specialist, the patient is getting a more robust understanding of what's going on.
And going back to what you were saying about trigeminal neuralgia, at least in dentistry, also we're teaching now a new awareness, like for two things, right? What about from the neurology setting? The patient has sharpshooter electrical pain, the trigger is intraoral. If it's pain inside your mouth, the first practitioner you're gonna see who will be maybe the dentist. That the dentist knows that could be a possibility of a disorder that doesn't deal with teeth. But also it's important, and we discussed that in our paper, what about that actually that weird trigger actually is not trigeminal neuralgia? What about if it's a cracked tooth? Has that singy sensation too? So you see it's two ways. One, to teach dentists to learn about this disorder. And, we have learned, but, it's much more awareness now that it is great that, this disorder, you're not going to treat with dental procedures, right? It's medical, and vice versa, that the neurologist also has the awareness that, oh, it's central trigger. Have you gone to the dentist? Have you checked that out?
So what should neurologists know about dental sources of pain?
Well, maybe they should read the paper.
Yeah, you need to read the paper. Yeah.
Top 3, don't treat this with gabapentin.
Like, well, dental pain is not going to be resolved with gabapentin. That we need to make a diagnosis, it's an examination, comes with a radiographic evidence that shows that maybe it could be a cavity or could be a problem, in the periapical tissues of the tooth that is giving the symptomatology. Not only dental, could be a lot of different disorders inside their mouth that can produce pain. That also the readers can check our paper and learn about and see the wonderful interesting pictures that we have added there.
Yeah. And so why don't we talk a little bit about TMD disorders and what is the new thinking around these conditions?
Well, I will say for the last decade, maybe a little bit more, has been a change in the evidence-based understanding of the etiology and pathophysiology of temporomandibular disorders. Imagine that was a shift in the paradigm that in dentistry prevailed for a long, long time. That really focused, and I would call it the natological mechanistic point of view. What I mean by that was focusing your bite, your occlusion, how the relation between your maxilla and mandible, that was the only issues that would create in temporomandibular disorders. So now we know that temporomandibular disorders are complex, are multifactorial, and you need to understand them and see them within a biopsychosocial framework. And these dictate the main way to management, or the primary way that we start will be conservative, reversible, and based in evidence, the best evidence available that we have.
And what about for trigeminal neuralgia? Is there newer kind of classification around trigeminal neuralgia? And what are some key points that we should consider when diagnosing these patients and treating these patients, Dr. Barad?
There haven't been any new diagnostic criteria, but I would say that there's been an increased awareness that classical trigeminal neuralgia is more likely than not related to neurovascular compression. Or maybe I should say neurovascular contact or compression. There is a developing grading system of that's in evolution as we speak. I think it's an exciting time for facial neuralgias because it's opened the door for us to look at other neuralgias also as vascular compressions and to think about how we can treat them with decompression or possibly with peripheral nerve stimulation or medicine or Botox or who knows what the future is going to hold. But it is, I think, a change in the way we are thinking about the definition of neuralgia, of trigeminal neuralgia, in that it is caused by a compression, which is different than other neuralgias in other parts of the body. I just want to classify there's about maybe 10, 12% of people who present with classical trigeminal neuralgia who there is not evidence on imaging of a vascular contact or compression, but the majority of cases do seem to have somewhere in the spectrum from contact to compression.
Even contact I find to be a bit vague. Sometimes say, well, thanks for letting me know that they're touching, but and then some of the neurosurgeons have different perspective when you open the patient up. So I didn't know about the grading,
Yeah,
but
I think you've hit on it exactly. Like that is a big problem in the field right now. How do we understand what patients will be the best patients for surgery? And it used to be that you have the classical trigeminal neuralgia symptomology plus some imaging that shows something versus nothing. And now we're getting into parsing out the imaging and trying to understand who's the best candidate for that with the imaging.
Dr. Romero, anything to add?
No, that I agree about that, and I think now maybe for the patients that I have seen with that, because in the orofacial pain setting, sometimes we're the ones that, oh, actually what you have is trigeminal neuralgia, so we start to have our multidisciplinary management. But when they come, oh, I already have an MRI doctor, and they say that it's a compression, but what degree? And some patients that they don't have symptoms can have a compression. And I'm thinking maybe, right, that later on when we have more fine and maybe nicer imaging, we're going to really find out, or if it's the cerebellopontine angle is the measurement has some other characteristics, who knows? So I think for trigeminal neuralgia, the things is still evolving, right, for our understanding and how to help us to make more, I will not say definitive diagnosis, but maybe some parameters will change in the future.
So now we have a lot of people listening, international folks listening, and they always want some treatment tips, some clinical tips. So can you give us a little bit of clinical insight to how to treat patients with trigeminal neuralgia? And when you're seeing patients for second and third opinions, what might you see that may explain why their pain is not well controlled? We'll get into interdisciplinary care, but in terms of pharmacology.
I think people are a little reluctant to use some of these medications, that neuromodulating medications, because in general it's an older population and they're rightly worried about falls and dizziness and confusion and low sodium. And so I think they hesitate to go to the doses that are needed to help with pain control. So a lot of my initial management is gingerly and gently titrating that to try to get to to try to see if we can get control of the pain.
Dr. Romero?
So I could add, for example, one thing that in the realm of orofacial pain, in addition to pharmacology, let's say that we have a patient with an intraoral trigger, and we were able to localize that intraoral trigger. Sometimes we can even also use topical medication. And in the topical medication, we can use, for example, an anticonvulsant, let's say gabapentin or oscarbazepine, for example, to add in the cream. And we call it a neurosensory stent. In mine, looks like an eye guard, but it's not an eye guard that can cover that area. So the patient can add that cream very delimited in that area. And that helps, can help with the pain. Sometimes what we can find is that, or at least in my experience, and when we add a topical, maybe we don't need to increase as much the systemic medication. Of course, depends from case to case.
So those are two great tips. Not being afraid to push those doses up in a safe manner and maybe with monitoring, as well as maybe utilizing more topicals. And I think we could probably hear a lot more from you on topicals at some other point. But thank you also for the table. I think it's really nice the way all the treatments are laid out. So what other cranial neuralgia advances have there been?
I would say the main advancements have been in applying the knowledge that neurosurgeons have learned from microvascular decompression of the trigeminal nerve to the glossopharyngeal nerve to the geniculate nerve, and really trying to optimize imaging and optimize neurosurgical techniques to try to treat these neuralgias. If the patient has failed medicine, if the patient is a good candidate for surgery, and if the patient desires that.
Great. So now let's talk about multidisciplinary approaches. I know both of you are big fans of that, and you may do things a little bit differently at your institutions, especially with your background. So maybe Dr. Romero, do you want to tell us about your experience, and then we'll have Dr. Barad.
Well, in my experience for multidisciplinary management, let's say, depends, of course, also the disorder we're talking about. But let's say, for example, about temporomandibular disorders. You know that for TMD is one of these overlapping pain conditions. And we know that TMD is comorbid with primary headache disorders, especially migraine. So we're able to utilize, the expertise of neurologists specialized in headache with me, for example, a orofacial pain person that is helping me manage a patient with this comorbidity. This is super effective because we know the presence of TMD in a migraineur can help the disorder to progress to a more chronic form. So you see, this is super important and effective to provide, optimal care for the patient. For example, in the patients that I do see with neuralgias, like in addition to trigeminal neuralgia, let's say nervous intermedius neuralgia, that sometimes they can come to me like, oh, the pain is in my ear and my ENT, or I think maybe it's my TMJ. But the pain is sharp shooting inside the ear, doesn't follow for the diagnosis of temporomandibular disorders, and I can maybe help the patient to get a proper imaging or already analyze it with a neurologist to make sure. And maybe at least my way will be, maybe I'm the one that can catch those disorders and help, the patient to go for the next step.
Dr. Barad?
I think Marcela, Dr. Romero-Reyes hit on a nice point that maybe this group is not as familiar with, and that is that temporal mandibular dysfunction, TMD, is one of the disorders that we call chronic overlapping pain conditions, or COPCs. And those include headache, it's not specified, fibromyalgia, irritable bowel syndrome, chronic pelvic pain, and several other chronic pain syndromes. And they suggest a central sensitization to one's pain. And the way that we treat centrally sensitized pain is not just through medications, it's in a biopsychosocial framework, because we see much higher rates of depression and anxiety in this group. And so using a pain psychologist to help the patient develop coping strategies to help them manage their pain, using a physical therapist to help them learn the stretching exercises, and using medications to help with not only with their pain syndrome, but also sometimes with their psychiatric comorbidities. And then additionally, procedures sometimes play a role in the process to help usually turn down the pain. Interestingly, when we look at trigeminal neuralgia, we see much less overlapping pain disorders. It's much rarer to see somebody with TN who has other COPCs or the kind of chronic levels of depression and anxiety that we see in these patients. So the approach is very different, and I think it requires the use of a multidisciplinary team to help guide the treatment pathways for these patients.
Today I've been interviewing Doctors Meredith Barad and Marcela Romero-Reyes, whose article on orofacial pain appears in the most recent issue of Continuum on pain management and neurology. Be sure to check out Continuum audio episodes from this and other issues, and thank you to our listeners for joining today. This is Dr. Teshamae Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, you'll love the journal, which is full of in-depth and clinically relevant information important for neurology practitioners. Use the link in the episode notes to learn more and subscribe. AAN members, you can get CME for listening to this interview by completing the evaluation at continuumpub.com/audiocme. Thank you for listening to Continuum Audio.